Thank you, Dr. Sunil, for that.
The topic I've been asked to talk about is infection prevention and antibiotic stewardship in obstetric HTU and ICU. I'm sure you all know what antibiotic stewardship is. It's basically appropriate use of antibiotics in this, we have a lot of resistance emerging now. Even in community-acquired infections, there's a lot of resistance. That's why this antibiotic stewardship has kind of become very important nowadays. Okay, I'll just start with a brief case scenario. A 37-year-old lady, third gravida. She is a known diabetic for 5 years with uncontrolled diabetes during antenatal period. Around 24 weeks of gestation, she had a urinary tract infection treated with amikacin, I think. And then at 30 weeks of gestation, she was admitted to the hospital with fever and flank pain for 5 days. Okay, and appropriate cultures were taken, blood and urine. She was started on ceftazidime sulbactam. But over the next 2 to 3 days, she actually deteriorated. She became hypotense, anuric, and hypoxic. She had to be ventilated. Okay, so she had multi-organ dysfunction. So by then, the urine culture and blood culture grew Klebsiella, which was kind of resistant to most of the antibiotics except colistin. So her antibiotics were modified to meropenem and colistin. So despite modification of antibiotics, ventilator supports, dialysis, with all these measures, her condition gradually improved, but she had intrauterine fetal demise and she had residual renal impairment. So what could have been done to prevent this morbidity, or sometimes she could have died in this thing. So if it was an older patient, the death would have been almost there for this patient. So there are many things that could have been, maybe adequate sugar control in antenatal period. There was a delay in seeking health care. She came diabetic and she came after 5 days of fever. So one thing, but what's striking is the initial choice of antibiotic was not appropriate for her. We started on ceftazidime sulbactam, which is a high-end antibiotic, a broad-spectrum antibiotic, but that was not adequate for her because it's a multi-drug resistant bug. So that's one. And second thing is, if some way we could prevent this MDR bug. So antibiotic stewardship is nothing but improving patient outcomes and preventing resistance. So when Fleming discovered penicillin, so everyone thought, or at least we thought, we conquered bacterial infections, and then penicillin is a magic bullet that can kill every bacteria. But the wise man mentioned it in the very beginning that, these bugs are smart, and then we keep using these antibiotics in inadequate doses, and we keep using it unnecessarily. The bugs will become resistant. These drugs will not work. So increasing antibiotic resistance to antibiotics is a huge problem. Nosocomial anywhere above 50%, even community-acquired infections 10 to 50% in various studies from our country. And the high antibiotic resistance has a huge impact in terms of higher morbidity, mortality, and prolonged hospitalization and costs. Okay, and when it comes to pregnancy, this increase in antibiotic resistance to antibiotics, it has more implications. The drug-related adverse drug reactions are more in pregnancy, and if a mother develops anaphylaxis to an antibiotic, okay, which sometimes is not really required. If she could be just having viral fever and she has hypotension, that could even kill the fetus inside. So, and also use of antibiotics in pregnancy and neonates, that may alter the fetal microbiome, gut microbiome, and there is some data to suggest that there are long-term implications that these fetus who are exposed to antibiotics in utero are at risk of developing some diseases like atopy and asthma in future. So antibiotic stewardship is nothing but it's a coordinated program focusing on appropriate use of antibiotics, which in turn will prevent emergence of resistance, will improve patient outcomes, and reduce spread of MDR infections. So the various components of antibiotic stewardship will just go one by one quickly. Identifying bacterial infection promptly, and initial choice of empiric therapy, which antibiotic to start with, and the dosage route administration, and then tailing drug to the bug, converting IV to oral, de-escalation of therapy, shortening duration of therapy, and there are many more interventions that can be part of this antibiotic stewardship. So coming to identifying bacteria infection promptly and differentiating it from non-infectious causes. So on the very theme of this particular conference is need of golden minute and golden hour. And there is plenty of data to say that in a patient with severe sepsis or septic shock, if there is delay in administration of appropriate antibiotic, not just any antibiotic, the right antibiotic, there is significant increase in morbidity and mortality. So on one side, we want to start the antibiotic promptly, and that too a broad spectrum to cover all the bacterial organisms possible for that infection in that patient. On the other side, we want to prevent emergence of resistance. Both are like they're in the opposite directions. And also there is overlap of manifestations of infectious and non-infectious conditions, especially in pregnancy. Like in the morning, I think Dr. Venkatesh Gupta talked about systemic inflammatory response syndrome. Like any patient with fever with SIRS features, we presume sepsis, right? So SIRS is nothing but tachycardia, leukocytosis, which are very common in pregnancy. Almost every pregnant woman has some amount of leukocytosis, so they're not useful in pregnancy to say that the patient has infection. So, and there are no easy way out. It's not easy to say whether if the patient is sick, whether she's suffering from an infectious etiology or something else. So morning, I think already it was talked to Q-SOFA and OM Q-SOFA, that is obstetrically modified QM-SOFA were talked about. So about if a patient is sick in ICU and you want to decide whether to start an antibiotic or not. So you want to know whether the patient is suffering from an infection or not. So how about using of biomarkers like procalcitonin? So procalcitonin, unfortunately, it is not a very specific thing. You know, it's in MI, pulmonary embolism, any critically ill patient, it can go up. It's not just elevated in infections alone. So maybe with newer diagnostics, newer microbiological tools like, real-time multiplex PCR, where, we know that there is a bug in the blood and then probably which bug, which is not a reality as of now to most of us, but that in near future may be of help. But as it stands now, to decide whether to start antibiotic or not for a patient in ICU, it's the meticulous clinical examination and our clinical judgment as of now. In a hemodynamically stable patient, we should not rush to start an antibiotic. In a patient in shock, yes, we have to cover for an infection, but if the patient is stable, I think we can take some time before we start antibiotic. So I think this slide was put up again in the morning. There are plenty of non-infectious conditions that can mimic sepsis in pregnancy, like pulmonary embolism, amniotic fluid embolism, pancreatitis, etc. And this OMQ SOFA, which just looks at actually the SOMAN, Society of Obstetric Medicine of Australia and New Zealand, for the pregnant women in ICU, they use this OMQ SOFA as a screening tool for sepsis. But you know that hypotension, respiratory tachypnea can be there in cardiac failure as well. They can be there in pulmonary embolism as well. So the problem here is, yes, it's a good screening tool, but the specificity is poor. We may be giving antibiotics for many pregnant women who are sick because of some non-infectious etiology. So that's what this antibiotic stewardship is all about. We want good patient outcomes. At the same time, we want judicious use of antibiotics, not unnecessary use of antibiotics. So next, choice of antibiotic. That is the empiric therapy before we have our culture reports. So for this, there are no, I don't think there is any particular antibiotic. It depends from how sick the patient is, what is the source of infection. If it's urinary tract infection, it's likely to be E. coli, gram-negative bug. If it's wound infection, it's more likely to be a gram-positive staph, strep, etc. So source of infection, severity of sepsis. If the patient had a recent antibiotic exposure, I think we should try to choose another class of antibiotics. Patient recent culture reports will give us a clue what to start now in this particular episode. And we must all have local antibiograms. Each hospital microbiology department should periodically give out antibiograms of that particular hospital, so you know what bugs you're coming across in your hospital, and then what are they susceptible to, which antibiotics they are susceptible to. So these will help in choosing the initial antibiotics before we have a culture reports with us. So next is dosage, route and administration. Dosage of antibiotics is very important. Often we see that there is underdosing of antibiotics. Like I often see piptazo 2.5 TID, whereas it's actually 4.5 QID. We should never underdose our patients, whether they are pregnant or not pregnant. And then dosage adjustment should be there. If the patient is on dialysis, the dosage should be adjusted. And then the way of infusion, how do you give it as a bolus or infusion? Like let's say there are some bacteria, some antibiotics which work by concentration dependent killing. Like some antibiotics like carb venom, cephalosporins, time dependent killing. Time dependent killing means the antibiotic concentration in the blood has to be above the MIC for at least 90% of the time. That's why we give carbovenoms as prolonged infusions. Like meropenem is given as 3 to 4 hour infusion instead of a bolus or a short infusion, because they act by time dependent killing. You want to maintain the concentrations above MIC for at least 90% of the time. So next is tailoring drug to the bug. So once we have cultures, we need to narrow the spectrum, modify the antibiotic according to the culture reports available. And converting IV to oral, again once we have cultures, if the patient is on the improving curve, if the patient, the bug is susceptible to oral antibiotic, we should switch to oral. And then next important thing is de-escalation of antibiotics. This is actually an important aspect of antimicrobial stewardship, but the most difficult part again. See, if we start a patient on a broad spectrum antibiotic, somebody who is very sick, and then once we have cultures, we know what bacteria it is, then we can just narrow down the spectrum of the antibiotic we are giving. If you've started on multiple antibiotics, if you know the bug, then just give that particular antibiotic alone. But even if in a sick patient, let's say somebody post-op is in septic shock, we've started the patient on vancomycin and meropenem, but then we have a culture which grew E. coli, which is sensitive to amikacin, then we can stop all those antibiotics and step down to amikacin. Let's say even if the cultures are negative, if the patient is improving, even then we can step down, we can stop vancomycin, because things like MRSA are usually, you know, they grow in cultures unless patient received antibiotics prior to obtaining cultures. And over the, you know, we started antibiotics, 48 to 72 hours later, we have more information of the patient, we have radiological information, we have more clinical information, we have the cultures, and if we feel the etiology is not infection, it's pancreatitis or something else, then actually we should consider stopping antibiotics in that patient. Even if the cultures are positive, there is reluctance among clinicians. If the patient is improving with the initial broad spectrum antibiotics, even if the cultures are positive, many clinicians have this reluctance to narrow down the spectrum or change the antibiotics or step down the antibiotics because the patient is improving and they don't want to. They say no, never change, you know, a winning track kind of a thing. So how about shortening duration of therapy? See, the longer the bugs are exposed to these antibiotics, you're giving more time for the bugs to develop resistant mechanisms. So shortening the duration of antibiotics is probably one of the most powerful strategy to reduce antibiotic impact on resistance emergence. Unfortunately, most guidelines still recommend relatively prolonged or imprecise duration for patients with infections in ICU. So we need to look at emerging data which are looking at shorter durations. And in fact, there are studies on ventilator-associated pneumonia, except for Pseudomonas and Acinetobacter. Most of the other VAPs, whether it's 7 to 8 days or 2 weeks, the outcomes are same. So we need to be looking at shorter durations of therapy because prolonged therapy facilitates colonization with antibiotic-resistant bacteria and which may precede recurrent infectious episodes. So these are some of the components of antibiotic stewardship. So what are the other helpful interventions? So obstetricians, if they are when they are managing sick parturient women in ICU, they should liaise with their microbiologist, physician or ID physician and intensivist. And some of the hospitals in West, they have this antibiotic restriction. Unless the ID physician gives a nod, they cannot start an antibiotic, but I think that will delay in starting antibiotics and I think treatment will be delayed. I don't think it's very helpful in our setting and most of us don't have an ID physician working for us. And moving away from HDU and ICU setup, see asymptomatic bacteriuria and across the globe I think they treat asymptomatic bacteriuria in pregnant women. Probably that is the only state where asymptomatic bacteriuria is probably treated, assuming that will prevent complications like pyelonephritis in the mother and then reduce incidence of preterm birth. But I will actually in the next slide show you what Cochrane talks about. Cochrane's systematic review talks about evidence for asymptomatic bacteriuria treatment. And prophylactic antibiotics for PROM and C-sections, there is systematic reviews and meta-analysis to say that they are definitely useful in preventing maternal infections. But what is the effect of these antibiotics usage during pregnancy? In the next generation, we don't know actually. So if you actually put up search words like antibiotic stewardship and obstetric critical care, there's not even one single article that I could come across except one in neonatal care. There are some in before gynae practice. So there is scanty of literature. Whatever I'm talking is actually extrapolating from non-pregnant guidelines. So I think FOGSI should liaise with one of the infectious disease societies like CIDS, Clinical Infectious Disease Society of India, and then formulate guidelines, relook at antibiotic practices. So what does Cochrane talk about? Cochrane analysis about treatment of asymptomatic bacteriuria. This was published in 2015. While antibiotic treatment is effective in reducing the risk of pyelonephritis in pregnancy, the estimate of this effect is very uncertain because of the very low quality of the evidence. Reduction in low birth weight and preterm birth with antibiotic treatment is consistent with theories about the role of infection in adverse pregnancy outcomes, but this association should be interpreted with caution given the very poor quality of the included studies. So everybody treats asymptomatic bacteriuria, but unfortunately the evidence to back it up is not of good quality. So no antibiotic stewardship program is complete without preventive aspect. If you can prevent, that's the best thing. Identify patients at risk of nosocomial infections in ICU and hospital. The cheapest and the most effective proven tool is hand hygiene, and that must be observed. We must follow standard precautions to reduce transmission and strategies to reduce ventilator-associated pneumonia, central line associated bloodstream infections, and catheter-associated UTI. And as and when required, we need to isolate the patient for his own health in neutropenic patients and to prevent spread of infections for the safety of other patients. So concluding, we need to start smart, because if the initial choice of antibiotic is not good, the patient outcomes are going to be worse. But then after 48 to 72 hours, we need to focus based on we need to review our clinical assessment and decision. We may stop the antibiotic if we feel that it's not an infection. We may switch IV to oral. We may change the antibiotic or narrow the spectrum, okay, or continue depending on the clinical response, the more data that we have in the culture reports. And we must remember that antibiotics are not antipyretics. Every fever is not an infection. It may be viral fever, it may be drug-induced fever. Prolonged labor itself can cause low-grade fever. I think for want of time, I will end here.